We shall go on to our, amidst all controversies, we go on to our next speaker, next topic, which is what is the treatment for uveitis? No inflammation, or is mild inflammation okay? And we have our speakers, I think they could share the screen. Dr. Padmamalini, who heads the Department of Uveitis and Ocular Immunology at Narayan Nethralaya, Bangalore. She's going to be talking for, and Dr. Kalpana Murthy, who again heads the UV and ocular inflammation at Prabha Eye Clinic, would be talking against this issue. So let's look forward to the next interesting set of debate. On to you, Dr. Padmamalini.
Thank you, Dr. Chitra. At the outset, I'd like to thank ARC team for giving me an opportunity to speak for target therapy for uveitis. I'll be talking towards no inflammation. The next 6 minutes also will be covering about what's target therapy with the available review of literature. Now, how are we going to assess the uveitic activities with case examples with take-home points? The improved understanding of the abnormal immune response in various forms of uveitis has resulted in targeted therapy. Could be atypical cell populations or cytokine expressions or cell-cell interactions. Different patterns of cytokines are being expressed. We're using corticosteroids, antimicrobial agents, immunosuppressive therapy, and biologics are used as a target therapy to control the inflammation. However, the challenges remain if there is persistence of mild inflammation in the eye. Uveitic activity is assessed by the presence of anterior chamber cells and flare, vitreous hairs and cells, and retinal, choroidal, and optic nerve manifestations with the help of multimodal imaging. For the benefit of postgraduates, we take anterior chamber into cells into consideration and also the vitreous hairs for posterior segment inflammation. Standardization of uveitis nomenclature and grading as scheme of cells. In this, we need to have 0 cells to grade it as 0. The vitreous hairs is the current standard for assessing posterior segment inflammation and is accepted as a valid surrogate endpoint for disease activity, where we expect the vitreous hairs to be 0 to call this as no inflammation. We call the uveitis is inactive when there are no cells or grade 0 cells. We want all the patients to reach remission, that is inactive disease, for more than 3 months after discontinuing all treatment of eye disease. We'll move on to the case examples. Here is a 9-year-old boy treated as recurrent uveitis with topical steroids. Whenever they used to stop the prednisolone acetate, the child used to get the recurrence. At that point, patient was referred to us. On examination, in addition to the anterior segment inflammation, patient also had vitritis with vitreous hairs 1+. Fluorescein angiography showed perivascular leak in this child. In addition to the topical medications, we started systemic steroids and also systemic immunosuppressive therapy with methotrexate. This continued for nearly almost 2 years, and following which we could see the anatomical restorations, and also there was no perivascular leak in this case. It's important that we have to have absolute control of inflammation in these cases. The next is quantitatively, we can measure the amount of flare by using laser flarimetry. Here is a case of a JIA who had a flare, but the flarimetry showed 16.6 significant amount of flare, suggesting active inflammation in this child. Here is a case of an ARN following COVID vaccination. Inflammation patient has anterior segment inflammation and also the retinitis. The OCT shows full thickness retinal involvement. Following treatment with antiviral and systemic steroids, there is complete resolution of inflammation. The treatment we continued for about almost nearly 14 weeks in this case. Here is a case of a sympathetic ophthalmia where we have exudative detachment with the choroidal bulge, and systemic steroids helped us to control the inflammation in this case, and also the immunosuppressive therapy. OCT helped us to monitor the response to treatment in this case. Here is a case of a serpiginous-like choroiditis, but autofluorescence helps us to monitor the response to treatment. Here, hyperautofluorescence suggestive of an active inflammation. This is a healing serpiginous-like choroiditis. This is completely healed serpiginous-like choroiditis. Here is a case of a chronic VKH. During the review, visual acuity is 6.6. Patient has vitritis. The fundus is looking near normal fundus. The OCT is also normal. Do we watch or do we consider this as a mild inflammation? On slit-lamp biomicroscopic examination, we could see the recurrence of anterior uveitis. ICG shows multiple hypofluorescent dark dots suggestive of choroidal granuloma. We have to treat this condition as a recurrence of panuveitis with systemic medications. than considering as mild uveitis. We'll see a case example. We talked about tocilizumab now. Bilateral occlusive retinal vasculitis in a 45-year male. When he presented, he just had vitritis with cystoid macular edema to some extent. This is the timeline of the chart. The patient first started with azathioprine, then MMF was added, then the rituximab was given. So following which the patient presented at this point of time. He started cyclosporine, patient did not respond. In view of lupus antibody, anticoagulant was added. Adalimumab, partial response was there. Finally, we switched over to injection tocilizumab, following which the patient responded well. It took nearly about 2 years to reach that point. Here is a OCT showing diffuse macular edema in this case. So cytokine-based assays are available for personalized treatment for various autoimmune uveitic entities in the literature. Here at NN, we started doing personalized treatment for uveitis, where we use the tears and estimate the inflammatory markers in the tears using fluorescence reader. And based on that, we customize the treatment. For this particular patient, when we see the interleukin-6 was elevated in the right eye, following tocilizumab treatment, this is within 4 weeks, we could see the resolution of the macular edema in this case, and the IL-6 level also have come down from the tears. The targeted therapy to control the inflammation of uveitis is the way forward. No inflammation should be our aim, and we should aim for complete remission. Mild inflammations can lead to chronic complications. However, conditions like Fuchs, what we discussed earlier, can have mild inflammation. I would like to conclude with this. The spark is like a mild inflammation. When we don't control the spark, it can lead on to full-blown fire. So it's important that we control the spark so that we don't lead with fire. The similar way, we need to control the mild inflammations. If we don't control it, we can land up with full-blown uveitic entities with complication. I would like to acknowledge our team members. Thank you for your attention.
Thank you, Dr. Padmamalini.